A very good morning to all, and welcome to part one of our two-part webinar series on New Frontier in Sports Medicine. This event is proudly organized by SGH Department of Orthopaedic Surgery and Patient Liaison Service. Before we begin, we would like to remind all viewers to submit a question by clicking on the Q&A button on the Zoom function below. Without further ado, let's welcome Prof. Andrew Tan, who is the head and senior consultant at SGH Orthopaedic Department, where he will share more insights on sports medicine and what the department has to offer. Prof. Tan, over to you.
Thank you, Min. Firstly, a good morning to everyone. And on behalf of SGH Orthopaedics, I would like to welcome all of you to our Sports Medicine Symposium. So this symposium will consist of two sessions. One this morning and the other will be conducted next Saturday. And we hope through this symposium to be able to provide you tips and advice on injury prevention, joint care, as well as to give you updates on sports medicine therapies as well as sports rehabilitation. We hope the symposium will be educational for all of you. And with the knowledge gain, we hope that you will be able to lead an even more active lifestyle, to return to sports and to do well in your sports, and also to take even better care of your joints and your health in general. Now, we will try our best to answer as many questions as possible. So we have a dedicated session at the end, a Q&A session, where all of us, the speakers and myself, will come together as a panel to address your questions. But there might be many questions coming, so what we want to do is, along the course of the session today, if you have questions, feel free to type them into the chat box, and our speakers will find time whenever possible to reply by typing in their responses. All right, and before that, before we start the forum proper, I just like to have 10 minutes of your time and attention to introduce SGH Orthopaedics and Sports Medicine. Can you all see my slides?
Yes, Prof. Yes, yeah, we could.
Okay, sorry, I have to go back again. So, just a short introduction to SGH Orthopaedics and Sports Medicine. We are the oldest, the largest and most established orthopedic department in Singapore. And we have a strong and experienced team of 41 consultants organized into 7 subspecialties. And these subspecialties are as seen on the screen here: adult reconstruction, spine, sports medicine, musculoskeletal tumor, trauma, foot and ankle, and acute care. And within each subspecialty, we are well-recognized and well-trained clinicians practicing at the highest level in their respective subspecialties. This setup allows us to have a comprehensive suite of orthopedic services and to provide high-quality care to all our patients. We believe strongly in providing high-quality care to our patients, care that is based on values of integrity, discipline, patient-centeredness, compassion, respect, and collaboration. And this very much underlines our mission. And our vision is to be the premier orthopedic department in the region and beyond, leading innovations and breakthroughs in clinical care, research, and education. We provide orthopedic care to about a quarter of all patients nationwide, which amounts to more than 120,000 outpatient visits and 8,000 surgeries per year. And we are the only orthopedic department internationally to offer a unique suite of clinically audited pre-surgery, surgery, and post-surgery care programs. And we have a world-class orthopedic diagnostic center, which measures performance and treatment outcomes that matter most to our patients, and in doing so allow us to better improve their quality of life, as well as the care that we provide. And we are recognized as the leading orthopedic center in the region for minimally invasive or keyhole surgery and robotic surgery. Other areas where we are leading breakthroughs and innovations include joint preservation. You will hear from our speakers on this over the course of this symposium. And as I've said earlier, minimally invasive surgery is performed extensively in the department. And for sports medicine surgeries, for that matter, whether it's surgeries of the shoulder, elbow, or ankle, most of our surgeries are done now through keyhole incisions. And because of this small incisions and less post-operative pain, our patients are able to go home on the same day. In fact, many surgeries done in the department are done on an outpatient basis or a short stay basis where they stay overnight and they go home the next morning. We also have started a very successful enhanced recovery after surgery program, or the ERAS program, which is based on refined and good surgical techniques coupled with very good perioperative care, thereby allowing us to discharge our patients a lot earlier. And this allows them to recover well in the comfort of their home and with their loved ones. We also believe strongly in similar step-down care, either to the community or to home. And for some of our programs, we have home visits by our physiotherapists and our nurses to ensure that good post-operative care is carried out. We started telehealth even before COVID-19. And of course, it has proved to be very useful during this COVID-19 times for us to continue to engage and manage our patients on an outpatient basis. Other endeavors that we have embarked on include AI, 3D printing, and other smart technologies like wearables and patient surgery journey apps. We are firmly committed to the 3 pillars of academic medicine, where through the pursuit of excellence in clinical care, education, and research, we seek to bring about the best possible care for our patients. This triangle of academic excellence has led to very high quality patient care in major academic medical centers in the world. And indeed, it is a strength of SGH and SingHealth. To meet the increased demands for sports medicine care, we have established the Singapore Sports Medicine Exercise Medicine or Singapore Sports and Exercise Medicine Center at SGH in collaboration with SingHealth Sports Medicine. So this is a one-stop sports medicine service where care is provided by a multidisciplinary team comprising of sports surgeons, sports medicine physicians, sports physiotherapists, and other healthcare professionals. And SGH Orthopaedics is the largest orthopedic sports service in Singapore, comprising of 10 consultant sports surgeons, providing a full suite of sports surgery expertise. And these are the services that we provide, including dedicated sports clinic operated on a team-based approach, sports rehabilitation, clinic-based interventions, minimally invasive and outpatient surgery, complex revision surgery in sports medicine, joint preservation surgery, exercise prescription, pre-participation screenings, clinical audits, and quality improvement projects. And we recently opened a huge rehab and sports medicine facility in our Outram Community Hospital building, which is located next to the Outram MRT. And the facilities include a large gym with a 50-meter running track for us to better assess and manage our athletes and the general population who would like to adopt a healthy lifestyle. Now, this year, SGH celebrates its 200th anniversary. If you look at the screen behind me, you will notice the SGH 200 logo. And very much like the story of Singapore as a nation, we have come a long way as a hospital, from a humble shed to the academic medical center that we are today. And some of you may know that over the last 3 years, we have been voted one of the top 10 world's best hospitals. And this is something that gives all of us tremendous pride. But more importantly, it has given us the motivation and the sense of purpose to want to do even better for our patients. And along with that, SGH Orthopaedics strives to be a world-class orthopedic department and to provide the best possible care for all our patients. With that, I thank you. Now, I'm going to now move on to the forum proper, and I'd like to introduce the first speaker, and that's Dr. Benjamin Ang, who is a consultant with the department, and his topic is on saying goodbye to shoulder pain and stiffness. Ben?
Thank you. Thank you, Prof. Very good morning, ladies and gentlemen. Thank you once again for joining us for this public forum. For the next 15 minutes or so, I will first be sharing with you about the common problems with the shoulder joint, and towards the end, the treatments available, so that hopefully you will be able to say goodbye to shoulder pain and stiffness. Because there are so many conditions and so little time, I will be focusing on the more common causes of shoulder pain and stiffness namely adhesive capsulitis, commonly known as frozen shoulder.
You might want to speak a bit louder, Ben.
Sure.
The audio is a bit soft. Yep.
Thanks, Prof. So so as I was saying, I'll be focusing on a little more on the more common causes of shoulder pain and stiffness, such as adhesive capsulitis, commonly known as frozen shoulder, rotator cuff tears and tendinopathy, subacromial impingement and bursitis, and biceps tears or tendinopathy. Other common causes of shoulder pathologies like labral tears, shoulder dislocation, and shoulder joint arthritis, which we will not have time to cover. However, if you have any specific questions about these, please ask them in the Q&A and we will address them. So some background before going into frozen shoulder. The shoulder joint is a ball and socket joint between the scapula, which is the shoulder blade, and the humerus, which is the upper bone of the arm. It is also known as the glenohumeral joint, the articulation between the glenoid fossa and the scapula and the head of the humerus. The head of the humerus is much larger than the glenoid fossa, likened to a golf ball on a tee, giving the joint a wide range of motion at the cost of inherent instability. To reduce the mismatch in surfaces, the glenoid fossa is deepened by a fibrocartilaginous rim called the glenoid labrum. This is seen on the picture on the right. The shoulder is the most mobile joint in the human body, and thus it is also very prone to injuries, impingement, and instability. Although these photos depict extreme cases of hypermobility, which most of us do not have, our shoulders are extremely flexible, giving us movements of adduction, forward flexion, extension, medial rotation, lateral rotation, and a combination of these to produce circumduction. When this range of motion is limited, our daily activities may be compromised, and that is when we frequently decide to see a doctor. So the most common complaint we hear in the shoulder clinic is pain and stiffness. And the most common diagnosis is that of adhesive capsulitis or frozen shoulder. It is characterized by shoulder stiffness, pain, and significant loss of passive range of motion. The cause may be primary or idiopathic, meaning there is no known cause, or may be associated with other diseases, most commonly diabetes mellitus. Secondary causes of frozen shoulder include trauma or injuries to the shoulder and all the other shoulder pathologies, which I will touch on later. The exact pathophysiology of adhesive capsulitis is unknown.
Sorry to interrupt, Ben. I
Yes.
think a lot of people are still writing in to say that your audio is soft. Maybe it will help if you come nearer to the mic
Okay.
or speak a bit louder. Yep. Sorry, carry on.
Thank you, Prof. Is this better?
Yep. And for those who may have problem hearing, it might also be useful to turn on the volume of their device. But Ben, you try to speak a bit louder. Thanks.
I will do that. Thank you.
All right. Sorry to interrupt.
No problem. So the most common hypothesis states that the inflammation initially occurs within the joint capsule, seen on the picture on the left, and the synovial fluid within the joint. The inflammation is followed by reactive fibrosis and adhesions of the synovial lining of the joint. This initial inflammation of the capsule leads to the initial pain that you experience. And the capsular fibrosis, as seen on the picture on the right, leads to adhesions and decreased range of motion. We'll now move on to rotator cuff tears and tendinopathy. Just to give some background, the rotator cuff muscles, namely the supraspinatus, the infraspinatus, the subscapularis, and the teres minor, are the muscles involved in moving the shoulder joint. The red part represents the muscles, while the white part represents the tendons. Tendons are what connects muscle bellies to the bone and thus are essential for movement. As seen on the image on the right, when the muscles contract, the tendon pulls on the bone, resulting in movement. With age, these tendons degenerate, which is termed tendinosis or tendinopathy. In a young patient with good healthy tendons, these tendons are unlikely to tear in the absence of significant trauma, such as a fall. However, in a more elderly patient, age-related degeneration predisposes these tendons to tears, which may occur with minor trauma or even no known trauma at all. The diagram demonstrates these tears in a supraspinatus tendon, seen over here and here, depicted by the blue arrow. With rotator cuff tears and tendinopathy, there may be pain and weakness in shoulder movements. In small partial thickness tears, pain may be the predominant symptoms. However, in a large rotator cuff tear, there may be profound weakness and with complete inability to lift up the arm. Moving on to the next condition of a subacromial impingement. The acromion is the lateral process of the scapular bone, and the subacromial space, as the name implies, is the space just below the acromion. So this space contains the subacromial subdeltoid bursa just above the rotator cuff muscles. When the arm is raised upwards, as seen on the picture in the center, the space is narrowed against and due to the upward movement of the humeral head, and this may result in impingement against the undersurface of the acromion. This may be aggravated by the shape of the acromion or any bone spurs on the undersurface of the acromion, which may further narrow this space. Impingement may result in inflammation of the bursa, resulting in bursitis, seen in this red bursa on the image on the right. This impingement and bursitis can result in pain, especially when the arm is raised to certain positions. It is also theorized that impingement may cause microtrauma to the rotator cuff and thus predispose to rotator cuff tears. The fourth condition I will touch on is biceps tendinopathy and tears. The biceps muscles consist of two bellies on the arm, which can actually be seen distinctly if the muscles are well defined, as the photo on the left, where you can see the short head and the long head of the biceps. The short head of the biceps attaches to the coracoid process, while the long head of the biceps attaches to the supraglenoid tubercle or the superior labrum within the shoulder joint. In the same way that the tendons of the rotator cuff may be affected by age-related degeneration, the tendons of the biceps, especially the long head of the biceps, may likewise be tendinopathic and susceptible to tears, resulting in shoulder pain. Now that I've briefly touched on the common conditions that may be responsible for shoulder pain and stiffness, I'll bring us through what happens when you see a doctor, followed by the treatment options available. When you see us, we will ask you questions about your shoulder, known as a history, followed by a physical examination. This helps us to understand your condition better and to formulate a list of possible pathologies that you may be having. Subsequently, we will also arrange further imaging investigations such as X-rays, ultrasound, or MRI. X-rays allows us to evaluate the bones for fractures or arthritic changes. However, we are unable to assess much of the soft tissues of the shoulder, so it is usually insufficient for a complete diagnosis. Ultrasound allows us to assess the soft tissues within the shoulder, such as the integrity of the rotator cuff, the condition of the biceps, check for impingement, among others. However, it is operator dependent and not always accurate. Therefore, MRI is the most accurate scan, but it is also the most expensive investigation. It allows us to evaluate all of the above and also assess for intra-articular structures, such as the labrum, which cannot be accessed with the X-rays or ultrasound. Treatment for shoulder pain and stiffness can be divided into conservative and surgical treatment. Conservative treatments are usually first line, which include rest and activity and lifestyle modifications so it do not aggravate your condition. This will vary depending on the pathology and the exacerbating factors, but usually avoiding lifting heavy loads and avoiding overhead activities may be beneficial. Analgesia or painkillers may be prescribed by the general practitioners to alleviate your pain, and among these include anti-inflammatory medications which can reduce the inflammation and swelling, resulting in pain relief. Painkillers also facilitate physiotherapy, which is the mainstay of treatment for frozen shoulder. Although physiotherapy in itself is unable to repair any torn tendons in the rotator cuff tear, it can help to increase range of motion and reduce pain. Injections are the next possible step, depending on the pathologies present. For frozen shoulder, hydrodilatation may be attempted to distend the shoulder joint. In this treatment, a needle is introduced into the shoulder joint and fluid is injected into the joint to dilate the joint and to break down any adhesions and the fibrotic capsule. What we commonly call H&L can also be injected for conditions such as subacromial impingement, bursitis, and biceps tendinopathy. The H stands for hydrocortisone, which is a steroid, and L for lignocaine, which is a local anesthetic. Although triamcinolone and marcaine are commonly given instead because of greater potency and longer duration of action. The local anesthetic will result in almost immediate pain relief and last for over 6 to 8 hours, while the steroid may take a few days to take effect and last for weeks to months. However, a caution is in cases of rotator cuff tear, steroid injections are generally not recommended as it may interfere with tendon healing. So, after the failure of conservative management, surgical intervention may be considered. Depending on the pathologist present, surgical intervention may be tailored to address each individual problem in an a la carte manner. So surgery is usually performed arthroscopically using minimally invasive techniques with the use of a few keyhole incisions, like what Prof mentioned. From these small incisions, a camera is introduced into the joint to allow us to visualize and evaluate the joint. Subsequently, other instruments are also introduced through the other small incisions to perform the necessary steps of the surgery. For frozen shoulder, capsular release is performed using a radiofrequency probe to release or cut the fibrotic capsule to allow the shoulder to attain full range of motion. The diagram on the right shows all-round release of the fibrotic capsule around the shoulder. This may be coupled with manipulation under anesthesia to complete the release and to ensure that full range of motion is achieved. In the case of rotator cuff tears, small partial thickness tears may be debrided or cleaned up, while full thickness tears usually require repair. Rotator cuff repair is performed with sutures, which are anchored into the bone, which can be seen in the diagram on the left. In recent years, bioinductive collagen scaffolds have also been developed to augment partial thickness tears without performing a repair, or even as an adjunct after repair of full thickness tears. When there is bursitis, the red inflamed bursa may be debrided and removed using a shaver or radiofrequency probe, and acromioplasty is also performed, where any subacromial bone spur is burred away or shaved off to prevent and reduce any impingement symptoms. These are termed subacromial decompression. With regards to the biceps, it may be a pain generator, and in instances of severe biceps tendinopathy or partial tears, the long head may be sacrificed or cut. This will be similar to a complete tear of the long head of the biceps. This is termed a tenotomy, which will bring pain relief. However, it may result in a Popeye deformity in someone with large muscle and less fat to cover, such as seen in figures A and C, where you can see a more prominent bump compared to figures B and D of the contralateral arm. To prevent this deformity, a biceps tenodesis may be performed. This is where the free edge of the biceps tendon after tenotomy is anchored into the bone instead of being left alone to reduce the deformity. These are just some examples of common surgeries which may be performed for the common pathologies, and is definitely not meant to be exhaustive. Thank you for your attention. Please feel free to ask any questions using the Q&A button, and we will do our best to address your queries.
Yeah, thank you, Ben. So if any of you have questions regarding shoulder pathologies or shoulder care, you may write in and Ben will do his best to answer them. Now, we would now like to invite our second speaker, Dr. Phua Ken Lee. He's a consultant with the SGH Orthopaedic Department, and his talk is on common elbow problems and what to look out for. Ken?
Morning, everyone. Thank you, Prof, for the introduction, and thank you, everyone, for tuning in. I'm Dr. Phua. I'm a consultant at the Department of Orthopaedic Surgery, Singapore General Hospital. I also hold teaching positions as an assistant professor at Duke NUS and as a clinical lecturer at NUS Yong Lin School of Medicine. A bit about myself. I'm I'm trained and brought up at SGH, and I've also had the opportunity to be trained by the best around the world in shoulder and elbow and minimally invasive surgery in France, in Switzerland, and in the US. I'm going to cover a couple of common elbow complaints, and I'm going to organize the common elbow conditions around these complaints, because this is how we make our assessment when we see a patient. The common problems around the elbow being a commonly neglected joint until problems arise. You can get pain, you can get stiffness, you can get instability where the elbow feels loose. You can hear weird clicking sounds, or you can feel clicking sounds. You can get numbness of pins and needles, both around the elbow, down the arm, and to the fingers. And of course, you can get lumps and bumps. The elbow joint, there's bone, there's cartilage, there's muscle, and connecting the muscle to the bone is tendon, and connecting the bone to the bone, there's ligaments. In the joint, there's cartilage, and around the joint, there's nerves. All of these can be diseased, can be injured, and can cause problems, and therefore result in the symptoms that I've explained. So in terms of elbow pain, most of us have heard of tennis elbow. That is usually pain at the outer side of the elbow, and it's due to degeneration in the tendon, which is shown over here. And this is usually due to repetitive movement. You develop small tears called micro tears in the tendon, usually not caused by trauma, by falling down, or it's usually either sports related, although less than 5% of my patients with tennis elbow play tennis. Most likely is occupation related. Beauticians, early childcare, teachers, dentists, hairdressers, everyone who has to constantly use their wrist and to lift up things can get tennis elbow. Golfer's elbow is the equivalent of tennis elbow with the pain on the inner side of the elbow. And this is also due to repeated hand and wrist movement. In the front, there's the biceps tendon, which can be painful in degeneration. It can suddenly tear for folks who are working out in the gym. And likewise, you can get small tears. You can get a degeneration in the triceps tendon, which is at the back of the elbow. For a treatment of tendon and muscle conditions, the first port of call is exercise therapy, which is taught by our physiotherapists at our physiotherapy department. For tennis elbow and golfer's elbow, as you can see over here, there's an option of using a brace. This is called a counterforce brace, which is used to help to reduce the stress and strain on the damaged tendon by adding compression around the muscles. Other options that we have include injections. Dr. Ang has covered the use of steroid injections for pain relief. Over here, you can see these vials. These tubes look like the tubes that we use for blood tests, and they are very similar. This is for platelet-rich plasma, where we inject. We take your blood in a small amount of blood, about 9 mils, and we put it into a centrifuge, so it filters out the red blood cells. And from there, we inject the yellow component, which you can see over here, back into the tendon. This is to help to promote healing and to help with pain relief. And it's relatively safe because it is your own blood. There's no drugs or additives that are used in it. Lastly, for some patients who have a pain which is persistent, refractory to all other non-surgical treatment measures, then we may perform surgery to repair the tear. In terms of the nerve, the most common nerve to be irritated around the elbow is the ulnar nerve, which is the nerve on the inner side of the elbow. If you ever bumped your elbow against a table or against a door, you might have had this sharp electric shock sensation running to your ring finger or to your little finger. And this is also why the humerus is called the funny bone. This nerve can get irritated by bumping into things. It can get irritated because it's loose, it's unstable in its position around the elbow, resulting in clicking. And it can also get inflamed and swollen. And that can result in pins and needles, numbness, or shooting pain down to the fingers. Here you can see this is a nerve conduction study where if we suspect there is a nerve problem after examining you, we may send you to the neurologist to get this nerve test done to confirm that there is a nerve problem. Commonly for nerve issues, the main thing is to avoid irritating the nerve. We can prescribe medication to help to manage the nerve pain. And for some patients, because either the nerve is unstable or there's a persistent inflammation, persistent irritation of the nerve, we may perform surgery. You can damage the ligaments. The ligaments are as a soft tissue which joins the bones together. Most commonly is due to a dislocation in the elbow. For some patients, after they recover, they find that the elbow still feels loose, and that could be due to a ligament tear. Usually we manage this by bracing. Some patients do require the ligament to be repaired. There are some patients who play a lot of sports, overhead sports, especially professional athletes. They may throw a ball until the ligament develops tears and then ruptures, and for that we may need to repair it. In terms of tests, the one thing about the elbow is a lot of our assessment is based on history, which is talking to the patient and examining the elbow. We don't normally need to do much tests in order to get to a diagnosis. But if we do, we have an option of getting an X-ray to check on the joint, ultrasound or MRI to look for ligament or tendon problems. And if we're looking for bone spurs, we may need to get a CT scan. Elbow stiffness is very common after injury, and most of the time it recovers on its own, or it improves with stretching, as taught by our physiotherapists. Elbow stiffness can occur due to joint or tendon contractures, usually after injury. Less commonly, similar to the knee and to the hip, you can get osteoarthritis in the elbow joint, where you have wear and tear in the cartilage, resulting in stiffness. Or you can get rheumatoid arthritis, 风湿病, which can cause inflammation in all the joints. This is an X-ray showing a patient that has osteoarthritis in the elbow. So the joint is narrow and the bones look very close together, and you can see all the bone spurs around the elbow. This patient has had prior injury before, many years ago. So we got this CT scan, and with technology, we can reconstruct the elbow into a 3D model, and we can see exactly where these bone spurs are blocking the movement of the elbow. And for this patient, because of the persistent stiffness despite non-surgical measures, I removed the bone spurs through keyhole surgery in order to regain his range of motion. Elbow instability or elbow looseness can occur after a dislocation, as what I've mentioned, where you tear ligaments, or it can be due to a chronic ligament tear. And as mentioned before, the treatment starts with a bracing, and for some patients, they may require a repair of the tendon. Clicking in the elbow is quite common. There are a few causes, and usually it depends on where the location of the clicking is. It could be due to loose bodies, means loose pieces of bone or cartilage in the joint due to wear and tear, which can cause clicking. It can be due to things outside of the joint, such as the ulnar nerve, which is unstable on the inner side of the elbow, sliding in and out of its groove. It could be due to snapping of the triceps tendon at the back, or it could be due to pieces of soft tissue trapped in the joint, which is called plica. Usually clicking is harmless and we would leave it alone unless there is pain or there is limitation in movement, or when it comes to the nerve, when they're starting to get pins and needles or numbness or weakness, then we may need to intervene either to remove the loose body, remove the excess tissue, or to deal with the nerve by stabilizing it. This is a video. On the left, you can see that this is the elbow joint. This is the arthroscopic or keyhole view of the elbow joint. And you can see this extra piece of bone, which is blocking a patient's elbow movement. And here I am removing that piece to allow for movement to continue. In terms of numbness and pins and needles, usually the numbness occurs around the fingers. And as part of our evaluation as to why there is numbness or pins and needles, we'll be looking for where the common areas when the nerve can be affected. Apart from the elbow and the wrist, nerves can get pinched in the neck, in the cervical spine. So we usually, if you were to see us in a clinic for numbness, pins and needles, we will evaluate you quite carefully and may send you for a nerve test. Around the elbow, there are two main nerves which can get affected by disease. The ulnar nerve, as I mentioned, is the nerve on the inner side of the elbow. It can get compressed or swollen within its location. It can also slip in and out, and known as a subluxing ulnar nerve. And this is very common. In fact, for most of you at home, if you want to try, you can put your hand on the elbow and try bending your elbow and straightening it. Some of you may feel this clicking of this tubular structure on the inner side of the elbow. It's harmless unless it's causing pins and needles or numbness or weakness. The other nerve on the other side, on the outer side of the elbow, is less commonly talked about. It's the posterior interosseous nerve. It can be compressed too, although it is less common. The more common nerve to have compression around the elbow is the ulnar nerve. Lastly is lumps and bumps. We can get lumps or bumps around the elbow, and most of us do worry, especially for a big lump, is it cancerous? What could it possibly be? There are common lumps that are around the elbow, can be, usually is olecranon bursa, which is like a cyst. It's at the end of the elbow, as shown over here, and it's filled up with fluid. Bursa is a normal piece of tissue which helps with gliding of the skin around the elbow joint. That's why you feel that you can move the skin around the elbow easily. For some people, it can get inflamed. For some people, it gets swell up, it can get infected. And I noticed this in particular due to COVID-19. After the circuit breaker, most people were working from home. So everyone is leaning over with a laptop, resting their elbows on the table. And I have a fair bit of patients who have come to see me with this problem with the bursa. The bursa itself is harmless as long as it's not infected. It can be left alone. Some patients are bothered because of the size and because it impedes their movement. I can always stick a needle inside and draw out the fluid, which is called aspiration. For some patients, the lump continues to recur, and then I may perform surgery. Other causes of lumps and bumps include gout. You can get your gout deposits at the elbow. If you have high cholesterol, you can get cholesterol deposits around the elbow as well. For this particular patient, his olecranon bursa, as you can see here, is quite big. And so he decided he wanted to have it removed through keyhole surgery. And this was performed as shown over here with a camera inside the lump. So I'm removing the bursa from the inside out. This is the view from inside the lump itself. Everything looks very big because it's magnified, but this is keyhole surgery. The instruments are between 4 to 5 millimeters in diameter. And this is how the final result looks after shaving away the tissue, the excess tissue. I have this final result here, which is the lump is gone with minimal or hardly discernible scarring as seen over here. Okay, I'm Dr. Phua. Thank you once again for tuning in, and thank you for your time. I'll hand this session back to Prof. Tan.
Thank you, Ken. There are some questions already addressed to you, Ken, so you may start to reply to them. And if you have any other questions with regards to Ken's talk, you may key into the Q&A box. Not the chat box, but the Q&A box. Okay, I would like to now introduce our next speaker. Dr. Lee Kong Hui is a consultant with the department, and his talk is on knee preservation. Kong Hui?
Yep, thank you, Prof. Yeah, thank you everyone for joining us for this webinar today. Okay, so I have about 20 minutes, so I just keep it informal and a kind of a friendly session. So how I see knee preservation surgery is like our department. Okay, so as you know, SGH Orthopaedics, we have a very strong knee replacement department. So I would like to see them like, you know, they are like the brand new car division, sales division, putting in brand new knee implants in the knee and everything. But along the way, as we know, along the years, we do know that not all knees, when they reach the end of their life or end of their COE, you know, they are bad, they need to be replaced. So that's why the leaders in our department and our hospital feel that, you know, there is actually a need to preserve the knees for those knees who are not too bad, that doesn't need to be replaced. So henceforth, that is where I've been sent to train in London, to train in preserving the knees if the knee doesn't look too bad. Okay, so I'll be covering this talk in mainly 3 areas: the background of knee preservation, the benefits of it, and what's the expertise that we have in SGH to provide our Singaporeans who wish to keep their knees intact. So the background of it all is that, as our population adopt a more active lifestyle, we tend, you know, in our younger days when we play soccer, when we play rugby, we do sometimes get meniscal injury, ACL injuries, meniscal injuries. And this, you know, if you leave it untreated, sometimes they are not picked up. Eventually, when you're old, they may lead to early onset of arthritis. And also number 2, we do know that Singaporeans, you know, we are leading a longer lifespan. Average is about 85 for females, maybe 80 for guys. So, and the thing right now is that for knee arthritis, what we commonly have for the last decade or so is a knee replacement. But we do know that knee replacement does have its finite lifespan, about 20 years to 25, depending on how you use it. So the talk is that if we are young, below the age of 50 or so, definitely we will try to preserve, if you have knee arthritis, we'll definitely try to preserve your knee as best as you can. When you're age of between 50 to 60, so that is the gray area. You have now that option if you are not keen to have your knee replaced. Above the age of 60, I would say the default is that, yes, that if you have knee arthritis, you are looking at replacement. But with current implants and technologies, for those patients above the age of 60 and they do not want to have their knee replaced, yes, we do have now options for you to consider. Yeah. So looking at this chart here, you guys can see, it's mainly, what we want is we want to keep the knee within this green zone, whereby we do not replace your knee. Because once we replace your knee, it's a one-way ticket. You know, if we start off with a partial knee, the next step forward is, if it fails, we are looking at total knee. And if it fails, we are looking at a revision knee and even what we call a fusion or even amputation. Not common, it's not common, but it can happen. So if you are above the age of 60, 65, low demand patient, yes, end stage arthritis of your knee, no question, knee replacement or partial knee replacement is the way to go. But if you are young, relatively young, I would say below 65 for males, below 60 for females, you may want to consider preserving your knee. We want to keep you in this green zone because also the thoughts are, as modern science, we evolve, we get better and better with our regenerative medicine like stem cell therapy and all. Who knows, like 5 years, 10 years, or 15 years. This is just postulation. If someone managed to get a good treatment modality without a surgery, you can still have a pain-free knee with a native knee intact. So, like I said, realizing that, our department has embarked on this knee preservation journey about 2 years ago. Yeah. So what's the benefits of, like what I said, extending the COE of your knee? So I see that our knee joint is really quite similar to the vehicle tires. Basically, once you reach the end of lifespan, yes, you have to replace it. But now, like I like to re-emphasize again, what if the damage is not too bad? Can you still keep your knee? The answer is yes. And what's the benefits of doing so? First, if you do a knee replacement at the age of 50, maybe you're looking at a revision knee at the age of like maybe 70 or 75. And we do know that, the younger you do a knee replacement, the younger you are, versus an elderly uncle who does his knee replacement at the age of 70, your chances of redoing a TKR is higher, according to, studies have shown. Depending on which study that you read, the risk of revision is about 2 to 3 times higher. And we do know also that if you keep your native knee, you can return to your active lifestyle, playing golf, playing tennis and everything. It has been shown in papers from the European centers. Cost-wise, yes, it's slightly cheaper, but I guess now with our government's, grants and everything, this factor, yes, is a plus-minus consideration for most people. But I think also a very important thing is that when you do a knee preservation surgery, you are not burning any bridges. It's like, it doesn't mean that if you do this surgery, you can't do a knee replacement in the future. The answer is no. You can still, doesn't work, yeah, you can still do a knee replacement. But the downside is that, yes, you have to go through 2 surgeries. Yeah, that's the downside. Chances of success, I would say, based on our studies and from overseas studies, is about 80 to 90%. That you do not, if you go through a knee preservation surgery, that you do not need a knee replacement in the next 10 years or so. So this is a slide from South Korea. I got it from the industry. So it goes to show that knee preservation surgery in South Korea is actually it's a 400%, 4 times increase over the last decade or so. So I would say that around the world, the Americans are not leading the way in this. It's mainly the Europeans, the South Koreans, and the Japanese who are leading the frontier in this knee preservation. I mean, I'm not sure why, but probably due to the industry influence in America. So for knee preservation surgeries, these are a lot of technical jargons. So it's basically osteotomies, and when we put plates, there are some surgeries that we put plates and screws. There are some surgeries that we do not put any implants at all, which I can briefly show you guys later, and a knee distraction. I'm pretty sure that most folks out there, you have not heard about all this. Actually, these terms, especially for this first part, is quite common in the 70s and the 90s. Osteotomies actually came before knee replacement, but knee replacement subsequently in the 80s and 90s, they had such good techniques and results. There's sort of like osteotomies kind of went into the background and into, passe. But right now, over the last few years, it's leading a resurgence as because we are living longer and we're having a more active lifestyle. I can show, this is the osteotomies of yesteryears, whereby we have big plates, big incisions. This is the old plate, This is the new plate that we are currently using. And the incisions that we make right now is very small. This is what, 3.5 cm, and two small sub-centimeter arthroscopic portal wounds. And the surgery is about an hour and a half. And the pain relief is quite significant. I mean, in terms of the medial joints, the joint space pain reduction, because we are using better implants, we are using more sturdier implants and bone grafts, and we use a cryotherapy. So basically, after surgery, we'll wrap you up with a coolant to reduce post-op pain and swelling. So, I'd like to share with you this X-ray. When you look at it, this X-ray, most probably, you'll need a knee replacement. But that's what I thought too before I went for my fellowship. But when I went over to the Europe and London, they are, for those, such patients, they do respond very well after surgery. So similarly, when I came back, I was initially very hesitant. I was quite worried as well, looking at such an X-ray in a 55-year-old gentleman. So, but fortunately, he's quite on the same page as me. He doesn't quite like to have his knee replaced. So we went for knee preservation surgery. So we straightened out his knee joint. Yeah, fortunately, he responded well. He's currently about 2 years out, and he's still quite pain-free in his knee joint. So I'd like to share with you this video. This is a video that's of an orthopedic surgeon. He's a surgeon himself from South Africa. So basically, he's currently leading one of our industry's companies here. And he's now 5 months post HTO. His operation was done by my mentor in London. As you can see that this is like bone on bone. He has inner knee pain. Yeah, we look at it. Yeah, this one most yesteryears. If you think that this is most probably we'll need a knee replacement, but he doesn't want. He personally doesn't want. So he went for a joint preservation surgery.
As funny as you can make it.
Yeah. So he's 5 months out, and is happily pain-free. Yeah. And leading this company, Arthrex company in Singapore right now.
As funny as you can.
So interestingly, in Japan, I managed to get this video from a Japanese surgeon. It shows this elderly lady, also medial-sided knee pain. I believe she doesn't want to have a knee replaced, so she went for leg straightening exercise operation. And this is about 3 months post surgery. She's 80 years old. So far I've not. The oldest patient I've done so far is about maybe 72, 73. Yes, we can do it for elderly patients, but do bear in mind that your recovery will be a bit longer. Yep. So this is one other surgery that I've started doing since last year, December. For patients with also inner knee pain, no implants, nothing whatsoever. This is still quite a controversial operation, not done in many parts of the world, mainly in China and India, whereby we just take a piece of the bone out. The thinking behind this surgery is that as we get older, our bones get softer. The outer part of the knee is reinforced by this extra bone, what we call a fibula, to support the outer part. So it's harder as compared to the inner part. So it tends to sink in towards the inner part of the knee. So to redistribute the forces across the entire knee joint, we elect to take away about 2 cm of the bone. I've done about 35 patients so far. I would say the success rate is about 95%. So this is one of the ladies, patients that I've done recently. I did both sides for her. She had inner knee pain, as you can see from this X-ray. Yeah, so there she is. First day, 8 o'clock.
在哪里痛呢？这边啊，一点啦。一点啊，今天这很好了，医生。比开刀之前好很多了。好多，哎呦，那是我走路要这样的。好 ，OK。可以前可以后的，现在。
Yeah, so this is still not a standard treatment for medial knee pain, but it is after extensive counseling with certain selected patients, then I'll perform this surgery. So one of the last treatment modality for knee arthritis, this is reserved for young patients, youngish patients, less than the age of 50, who has very bad arthritis, end stage, I would say. Both the inner and outer part of the knee joint is gone. Arthritic. What we can do is that we can pull apart the knee joint. It looks a bit scary, but this is the only procedure in the world that can relieve knee pain in an end-stage arthritis effectively in a youngish patient. How long do you put on this Wolverine-like structure over here? It's about 6 weeks. Yeah. Then after that, we take it off. Yeah. So it's done mainly in London, in Europe, Netherlands, Germany, and France. Yeah. So, sort of like to end it off, I'm quite pleased to say that together with my colleagues, we are performing more knee preservation surgeries than the rest of the hospitals in Singapore combined, whether restructured or private. And we are the only hospitals here in the whole of Singapore that's doing osteotomies with ligament reconstruction with ACL or PCL, realignment surgery with meniscal transplants for youngish patients, and a PFO, the one that you saw just now in the lady, and a knee distraction. So to end it all, I would say that knee preservation surgeries is in its renaissance phase. I think the Europeans, the Koreans, and the Japanese have given us much hope and inspiration. So, and I do hope that in the years to come, SGH will be the center that you guys can go to should you decide not to go for any knee replacement. Thank you. I'll hand over to our next colleague.
Thanks, Kong Hui. So we've come to our last speaker, and that's Ms. Sunny Tam, our SGH physiotherapist, and the talk will be on rehabilitation after injury and surgery. Sunny?
Hi, good morning. Thank you, Prof. So are you able to see my screen?
Yes.
Okay. So hi everyone, good morning and thanks for tuning in. So my name is Sunny and I'm one of the physiotherapists here at SGH. So my main area of interest is in sports injuries and rehabilitation, and I'm here to share with you the rehab journey after sports injury or post-surgeries. So a very brief outline to what we will cover today. We'll basically be looking at how rehab is going to be like, and also a mini case examples about the journey after a knee operation as well. So what should we do after an injury? So the body after an injury will tend to respond with the process of inflammation, and that's the body's way to heal itself. So the area that's involved might be painful, might be swollen, may be red, and may be warm to touch. And during this period, we would really want to protect the area and do no further harm. So we might want to avoid activities and movements that can increase the pain for the first couple of days. And swelling, as we all know, can be easily managed with elevation, moving the body part above the level of the heart, often and throughout the day as well. So after the pain has settled down, you might want to try to return to normal activities. So this include things like walking as much as you can tolerate. So rather than complete resting, optimal loading without exacerbating the pain at the acute stage actually promotes tissue repair and healing as well. So while having an injury acutely is scary, but what we know is that keeping a positive outlook is important for recovery and as the body heals. So rehab at this stage is mainly at managing the pain, managing the discomfort and swelling around the area. So things that can help will be things like icing, can be gentle massage as well. So there might also be focus on flexibility of the joints, of the muscles at this stage. And appropriate muscle conditioning as well, getting gentle muscle activation at the acute stage to prevent further deconditioning of the muscles. So of course, all this is paced properly and according to the bodily response at this stage as well. So as the pain settles down further, aerobic exercises can also resume with options that deloads the affected area. So for example, for a swimmer who has sustained a strain over the shoulder, he or she can resume and start an alternative such as stationary cycling and as such to maintain their heart and lung capacity and their function. And of course, throughout the entire process, all this is graded and all this are guided by how the body responds as it continues to heal. So moving on to the intermediate stage. So that's when we are expecting the inflammation to be dampening down and the tissues are maturing. So of course, different tissues heal differently and have different time frames and different extents of healing. But at this stage, advancing into this stage, that's when the individual is able to perform daily activities pretty well with fair flexibility and strength as well. And basically what we want to do is to build the body back up so that we will be able to be where we were before the injury. So that's when exercise therapy will come in, looking at strength, endurance, and at the later stage, even power training. So balance and position sense and motor control of the movement can also be affected after an injury, and this will be something that you want to incorporate into the rehab as well. So of course, the focus is also on maintaining the flexibility and cardiovascular fitness, and it's really to build ourselves back up after the injury. So of course, again, progression is gradual, is according to how the body responds in preparation for returning to activities or the goals that you might want to get back into. So then, moving on into the advanced stage, rehab is now geared more towards the individual goals. So it can be things like trekking, it can be things like jogging on the weekends, or recreational sports with your friends over the weekends, and even competitive sports as well. So that's the stage where the tissues are maturing or matured, and they are continuing to remodel itself. So this is also the stage where we might want to bring in sports skills that are relevant to the patient's goals or to the individual's goals, so that they are even stronger than how they were like before the injury. So an example would be what you see in the picture there. So basically, the athlete will need to go to the different cones and the different targets so they can practice changes in directions, pivoting, and changing and running as well, and speed. So you can also add on the difficulty level of the exercise, where the coach or the therapist can give them external cue, say go to the red cone, go to the green cone, and so on and so forth. And that can actually gear them back to how you would be like during an activity such as soccer and so on and so forth. So then moving on to after preparation to return to sports. So when would we know that we are actually ready to go back to our activity? So we are looking for both physical as well as psychological readiness. So there are actually established tests, guidelines out there that guide us through this process to make sure that functionally or physically, the athlete or the individual is ready to do so. More importantly than not, sometimes there might be associated fear and associated anxiety into going back to their sports. And this will be something that we want to pick up and talk and discuss with the individual before letting them go back to the activity and sports. So that being said, once they are deemed ready to go back into their sports, we want them to go back gradually and in a graded manner. So what that means is that they might be doing training with their teams to start off with, rather than diving straight to it. So it's like dipping the toes into the water, trying it out, and then getting some feedback with that activities before going full on to what it is like before the injury. So it can be so many times when the individuals or when the patients come in, they might then tell us that, or in the middle of the game, then they will feel like, that's when they get really tired, and that's only normal, and that gives them the awareness that they want to train further before going straight back into the activity or into the entire match, for example. So then even after going back to the activity, we will also want them to self-manage, continue with their conditioning and strengthening program to prevent re-injury as well. So how about if it's after the surgery? How would rehab be different? So the principles of rehab is largely similar, but you might be expecting some restrictions after the operation just to allow the tissue that's been repaired for the healing to take place properly. And throughout the entire rehab process, we also work very closely with our surgeons to make sure that the progressions, the milestone that's been achieved is comfortable between the surgeons, between the therapies, and then the individual as well. So to put it all into perspective, so let's take a look at Miss Q. So she's a 25-year-old lady who has undergone a knee surgery because of an injury while playing basketball. So her goal is to be able to run pain-free and then to return to basketball with her friends. So at the initial stage, she might be asked to use crutches to help her cope with the pain and the swelling fresh out of operation, and we'll teach her to do that. And we'll also encourage her to do icing, gentle massage to help to reduce the pain that she might have initially after the operation as well. So exercises at this stage is pretty gentle. We'll want her to move the knee, as you can see on the first picture, really getting the bending range of motion as allowed, as tolerated at this stage. And then the next one is actually the straight leg raise exercise. Basically, is getting her to contract the thigh muscles and lifting the entire leg up slightly. So a little bit of the load towards the thigh muscles as well, which is great at this stage for early stages after the operation. So balance exercises can also be incorporated at the initial stage, as you can see on the extreme right side. So this is where we get patients to stand on the wobble board, an uneven surface, to try and get them to balance a little bit, get back their sense of balance. So moving on, so as she continues to progress, pain and swelling is under control. There's not much pain with her daily activities. We might want to load her a little bit further. That's when the more weight-bearing exercises will be appropriate, such as the wall slides, as you can see on the extreme left-hand corner. So that's targeting the thigh muscles. It's kind of like a offloaded squat option at this stage after the operation. Step up, as you can see on the second picture, are also great because it requires you to move your hip and your knee together, and it gives them a sense of control over the joints of the hip and the knee as well. And then, of course, we'll also want to progress the balance exercises a little bit. That's what you can see on the right side, where we'll get them to stand on the wobble board, maybe a little bit of ball throw, where they react and receive the ball, throw the ball, and so on. So incorporating what they like to do in a safe way during this stage is actually great, because they'll feel encouraged to continue with the rehab progress. So then moving into the advanced stage, she would have, we'll want to test her strength appropriately. Symptoms are minimal. And then she will also have a doctor's appointment at this point to obtain clearance for jogging and for more loaded exercises. So then she has been able to pass the strength test. She has obtained clearance from her surgeons, and everybody is, and she's ready to commence jogging. And this will be the stage where we want to incorporate a little bit more of sport skills, such as the agility ladder, getting her to be nimble on her feet again, as you can see on the right side as well. Of course, not everyone who undergoes the rehab process need to progress to this stage. So it's really goal dependent. It's really geared towards to what you want to achieve after an operation or after an injury as well. So of course, the bottom line is we are also strengthening, we are also conditioning the muscle, maintaining the flexibility even at this stage. So then this is also a stage where we might consider bringing the patient on a treadmill to find out about how they are running, how they are coping after the surgery or even after the injury as well, to find out if there's any abnormalities in terms of their running gait, both from the side view and from the back view. So there are a few things that we might be looking for, depending on how the knee position when they land, the knee position of the pelvis, and so on and so forth. And if there's symptoms and if there's anything that we pick up that's worth practicing, that's worth training, then we will also intervene in that sense. So all in all, after her recovery process, she has obtained the approval from the surgeon to return to basketball. She has completed several physical tests, strength tests, to make sure that her muscles and she's ready to take on more load. And she also feels confident in entrusting the knee, trusting the body into going back to the sports, which is basketball. So at this stage, she will be returning to training with her friends, with her teammates, and then gradually to half a match, and then perhaps to the full match eventually. And all in all, even after going back to her basketball games, we would want her to continue with her strengthening exercises at the gym, getting her to practice her skills as well to prevent re-injury. So all in all, as we go through the rehab process, be it operative or non-operatively, the entire process is actually very well planned out, and it needs to be paced according to how the body feels. So it's not just a science where, you know, we look at muscle activation, we look at muscle range and as such, but it's also an art in planning a good rehab program. So an art because we really have to gear and tailor the program according to the patient's or the client's or the individual's goals, what their preferences are, their sleep, how and the things that they are going on in their lives as well. And that what makes rehab challenging, that what's makes rehab really interesting as well, and of course a rewarding journey to go through. So then I've come to the end of my presentation. Thank you so much for tuning in.
Thanks, Sunny. In case you all are wondering, that was Sunny herself in the photos and the video. Am I right, Sunny? Okay, so I think we now come to the Q&A session. We have about 20 minutes. And actually, I saw a lot of questions being posted. Maybe I would just like to start off by sharing some of the questions that were asked, because there were many questions that were of similar nature, and then maybe I'll get all the various members of the team to answer questions specifically directed at them. So there was a question regarding SGH Sports Medicine Center. How is it different from the other sports medicine center like in Changi? So actually we all come together under the SingHealth Sports Medicine umbrella. So, and of course, that's under the SingHealth cluster. And actually, the reason for coming together, it's very obvious. We want to leverage on the strengths of each hospital. You know that in SGH, we're very strong in sports surgery. Changi is very strong in sports medicine. And by coming together, we are trying to provide as comprehensive, as holistic as possible sports medicine care to all the athletes out there, whether they are elite or recreational athletes, or just anybody who wants to pursue an active lifestyle. So I've introduced the Sports Medicine Center at SGH, the members that come together to form the team, the facilities that we have, and it's still something that we're going to build upon so that we can work towards becoming a world-class sports medicine center. And the name that we have actually given to all these various satellite centers under SingHealth Sports Medicine is the Singapore Sports and Exercise Medicine Centers. So that's one question that I wanted to address. The next was the question on referrals. Referrals to SGH, you can make them either through your GP, your company doctors, or direct referrals, or if you want to come in as a subsidized patient, then you will have to go through the polyclinics, right? And another question that was on exercising. I know a lot of people in Singapore want to adopt an active lifestyle. In fact, as a nation, we are moving towards becoming a more active and a more sporting nation. And we are seeing actually, along with that, more sports injuries and people with more sports medicine needs. And that really is the reason why we are developing in a very big way our sports medicine center. But this question of wanting to exercise in spite of having some joint conditions, it's a very commonly asked question, very relevant. And it's important, as we always say, firstly, you must listen to your body. So if it hurts, it's your body warning you that it's time to slow down. So pain, obviously, counterintuitive as it may be, is a protective mechanism. It's your body's way of warning you something is not right. Like if you have your finger touch a hot kettle, you withdraw your finger. So listening to your body is so important, it cannot be overstated. Of course, when you go on your exercise regime, it's important to start off with warm-up. Like Sunny was alluding to, it's always important maybe to just jog for a few minutes and warm up your body before you start, working on those muscles. This is to prevent your core muscles from getting injured. And of course, do it stepwise. Don't go for the heaviest weights when you start out. Start with the smallest weight and then incrementally increase it. And exercise in moderation is always good advice. And this is something we'll talk a bit more in the next session when Dr. Fadzil, our sports physician, gives the talk about exercising. Now, there is also this question on osteoarthritis. Dr. Lee's talk, somebody was asking regarding knee conditions. It's really centered on osteoarthritis. And actually, Singapore is an aging population. The incidence of osteoarthritis is on the rise. But like I've said, we are also becoming more and more of an active and sporting nation. So this is something that we want to deal with. And in our department, we actually offer that choice to our patients. We have increased our treatment armamentarium to not just offer patients knee arthroplasty, but knee preservation surgery, or for that matter, even hip preservation and ankle preservation in lieu of a joint replacement, or even minimally invasive surgery like arthroscopy in lieu of a joint replacement. But of course, the treatment has to be individualized. Certain patients will certainly benefit from joint arthroplasty. And like Dr. Lee has mentioned, our department is very strong in joint arthroplasty as well. In fact, we are very well known regionally and internationally for our joint arthroplasty endeavors. But it's important, and we have started this in recent years, that extra option that we give our patients, because by giving them a wider choice, we can then tailor treatment accordingly and find what is most appropriate for them. And that's the whole basis of joint preservation. All right. Any of the panelists would like to raise any questions asked to you, which you feel it's important to discuss in this forum to the bigger audience? Anyone?
Ben, maybe we start with Ben first. We go Ben, then Ken.
We can do that.
Yeah.
Anybody with any questions? Or Ben, you want to start off?
So I think I see quite a few questions regarding how to prevent age-related degeneration. I think Sunny has also responded in the question Q&A as well. So there's a lot of concern about exercise or lifting weights and how it may affect whether it will cause the degeneration of the tendons. I think as Sunny mentioned, graded weights, controlled exercise is actually in general good for your health and good for tendon quality as well. Of course, if you go push it to the extreme and lift weights that you are not prepared for, especially with poor technique, then of course you are more prone to injuries and more prone to even tearing your tendons.
Yep. Thanks, Ben. Anyone, Ken?
Yes, I see a fair bit of questions related to injections. Injections is one of our methods of non-surgical management for a lot of our upper limb conditions. For the use of corticosteroids, as what Dr. Ang has mentioned, it's usually our first port of call if we're thinking of an injection, and it's mainly for symptom relief, to relieve pain. I see a fair bit of, I see some questions in the chat board as to whether it is preventive. The answer is no, it's mainly for symptom relief. As for platelet-rich plasma, the evidence for the use of platelet-rich plasma is in the use of tendon and ligament injuries, in tears, in augmentation after we repair Achilles tendon tear. The evidence for the use of platelet-rich plasma for knee pain, in particular osteoarthritis of the knee, is not strong yet. Our department is very active in terms of clinical and basic science research, and we will definitely get back to you once we have enough evidence that either supports or refutes the use of platelet-rich plasma for osteoarthritis of the knee. Studies are still going on and is work in progress.
Thanks, Ken. On that note about PRP, or for that matter, any new biologics, as we call them, that have come on board in recent years, I think this is where our department can come in very well to resolve a lot of questions that have been asked. Because we are a tertiary department, we're an academic department, we are strong in research, and we firmly believe that whatever we practice must be scientific and must be based on literature. So in many ways, we are in the right position to test out new technologies. Of course, doing this in what I call an RRS way, which is a responsible, regulated, and scientific way. So if we institute a management mainstream, it must be because we believe it's going to benefit our patients based on science. And it is true, new biologics require further testing before the answer as to whether it works or not can be, stated definitively. And this is something where, as a department, with the support that we have in the areas of research, etc., we will be in a very good position to address. And with regards to questions on supplements in general, I see a lot of questions on supplements. I think there's one question just asked about calcium. So calcium should be taken as prescribed. So there is a dose that you should take on a daily basis, depending on whether you're osteoporotic or otherwise. But take as prescribed, and it is not going to lead to the formation of stones or even the formation of spurs. And glucosamine is a question that's also asked a lot. Glucosamine at the end of the day is a vitamin. It is not something that in a way has a scientific pathway of working, unlike your antihypertensive, the medicine you take for high blood pressure, but largely a vitamin. But there are studies done where they randomize patients into groups with glucosamine and without, and there is a proven difference that it can work. But we also have seen patients taking long-term glucosamine with no effects. So at the end of the day, it's very much treated as a vitamin. Now let's see, maybe we go to Kong Hui first while we try to address more questions. Kong Hui, anything in particular you want to bring up?
Yeah, I mean, this is quite a good question by quite a lot of panelists, in the sense that they are asking what's the maximum age that a patient can go for knee preservation surgery. So I just like to stress to everyone, you just have to think of your knee joint as like your car tire. If your car tire is worn out completely, both the inner and outer parts of the car tire, that's without a doubt, you need to change the entire tire, which means a knee replacement. But if you are young, 30s, 40s, and you have totally bald tire, and you do not want to have your knee replacement, then yes, what we can do is that we can do a knee distraction. We pull apart your knee joint for about 5 mm for about 6 weeks. But that's not commonly done because our incidence of knee arthritis in relatively young patient, less than age of like 45, is quite low. Yeah, but so per se, if your knee arthritis is not too bad, affecting only a region of your knee, a part of your knee, whether is it the inner part or the outer part of your knee, so just like car tire, the inner part is worn out, what we can do is that we will make your car tire straight again. So similarly, we make your knees straight again. So once the knee is straight, your body is loading onto the good part of the knee. So henceforth, relieving you of the knee pain. Yeah. So I think that's mainly some of the questions that they asked. Yeah. So per se, there is no age cutoff. It's based on each individual's physiology, because nowadays Singaporeans are very healthy. A 70-year-old gentleman may look like a 55-year-old gentleman or early 60s, gentleman, and you only have a inner knee pain with medial inner knee arthritis. Yes, there's no need for you to do a total knee replacement. You can choose to undergo a knee preservation surgery. Yeah.
Thanks, Kong Hui. With reference to what Dr. Lee has said, so essentially there are two issues with regards to what is the best treatment option for you if you have osteoarthritis, which is cartilage wear and tear. So here we are particularly talking about the knee. So it really depends on the severity of the degeneration. If it is a very worn out knee, then you would have to go for a knee arthroplasty. The second important factor to consider will be the kind of lifestyle that you would like to adopt. So it's particularly useful for youngish patients who want to continue with a very high level of sporting activity. Certainly, a joint preservation would allow you to do that. But we do not want anyone to get the idea that after joint arthroplasty, you cannot adopt a healthy lifestyle. In fact, there are a lot of patients after joint replacements who will go on to play low-impact sports like golf. They go on hiking, not serious mountain climbing, but hiking and even gentle jogging. So a joint arthroplasty also allows you to restore your lifestyle. But of course, surgery is always considered as a last resort. In the early stages of treatment, it is where people like Sunny would come in. physiotherapy, it's important. Medication is important. Even wearing of braces and knee guards may be useful. And to address that often asked question, and I see it asked a lot in this Q&A box, is if you have osteoarthritis, does it mean you should stop exercising? Or for that matter, if you have osteoarthritis of any other joints, if you get pain because of cartilage wear, should you stop exercising altogether? And this is where it's important for us to, educate everyone that in many ways, our body is not like machines. You would think that if you keep on using the machines, you will undergo accelerated wear and tear, and eventually you will give up. But the human body is different. Exercising is important, obviously, for general health, for your cardiovascular health. But even for the joint health itself, exercising is important, even though you may have existing osteoarthritis or cartilage wear, because it helps to strengthen your muscles. The muscles that you strengthen helps to provide stability and core support to your joint. And it can prevent further wear and tear. It allows your joint to be supple, to have good range of motion, and that itself is also important for joint health. And of course, when you exercise well, particularly for weight-bearing joints like the knee, you will maintain your weight or you will lose weight, because more weight through the knees would also accelerate your wear and tear. So the notion that you should not exercise if you have an existing cartilage problem is not quite correct. Okay, Sunny, anything you want to bring up?
Hi. I think I saw a question with regards to post-operative care, about how soon physio should start after an operation, and I would want to maybe just address that a little bit. So with that question, it really depends on what operation it is to begin with, and then the extent of the surgery as well. So typically, post-operative care is guided by the surgeon's preference and the surgeon's considerations for recovery. So it can range from like 2 weeks to 6 weeks and so on. But typically we will start or we will commence therapy on the surgeon's note. And there was also a question about some concerns about running and then the agility exercises as well. So as what Prof. Tan has mentioned, the body is not like a machine. So whatever load we give to the body, as long as it's graduated, as long as you monitor the symptoms, as long as you listen to your body before you start and after you start an activity as well, it should be it shouldn't be something that you limit yourself into. But of course, that being said, if you have not ran for like 10 years, for example, we won't recommend you to go ahead and then go for a 10K jog tomorrow. So everything needs to be taken into consideration, how fit you are, how much you are doing at this point, and so on and so forth. So those are the two questions that I see out there. Any other inputs from?
Thanks, Sunny. I think Josephine has reposted a question, which is on calcium and glucosamine tablets. So generally, if you're talking about calcium intake supplements, that is not calcium intake that you can get from maybe food sources, generally it's about 800 milligrams per day. So again, you look at the calcium tablets you're taking, because it really depends on the strength of each tablet. So it's not about always 2 calcium tablets. I think that was the question. I'm trying to get back to it, but somehow I can't. And similarly, glucosamine is not about 1 or 2 tablets, because they come in different strengths. But normally we recommend 1,500 milligrams per day. And I believe it was Josephine who reposted that question. Now, but if you have joint replacement done, I think there was mention of a partial joint replacement done. As long as, there is still existing cartilage, it has not been totally replaced by an operation like joint replacement, then maybe you will argue there's value for the glucosamine. But if you're using it to treat your knee pain and it has already been replaced, so there's no more cartilage, then there would not be any value in taking glucosamine. Anybody from the panel has any questions you would like to answer? We still have some time, and in fact, I think this is probably the most interesting part of the whole symposium, to see how we can best address the questions and concerns from the audience.
I see a common theme for the upper limb questions, which is what are the things that we can do to preserve function in the shoulder and the elbow and the hand and the wrist, and also the neck as well and the upper back. I think part of the issue is that most of us are working from home, and it's already been more than a year since we've been working from home. And if you're in the office, if you're in the office and you're desk bound, usually you have a dedicated desktop. Everything is set at the correct height. With most people working at home, they're on their corporate laptop, crouched over a coffee table or dining table. And in fact, some of my patients tell me they are working with the laptop on the bed because they have to look after their kids. This causes a lot of neck pain, upper back and shoulder pain, elbow pain, and hand and wrist problems. So the main message here is to keep yourself active and to watch your posture. It's not just about posture as what your mom said about sitting up straight. It's about keeping your shoulders back. It's also about ergonomics, about having the screen, the keyboard and the mouse, the table and the chair all at the correct level so that you're not straining in order to do your work. And we all have to work, and I know COVID-19 has caused a lot of limitations in how we can go about our day-to-day work, but there's a lot of things that we can do for prevention. In terms of special exercises, core muscle strengthening, yoga, Pilates, and swimming is usually the way forward. Because if you have a weak core, you put additional stress on your extremities, and a lot of things are related. Things don't occur in isolation. So if you have a shoulder problem, yes, you can get pain up the neck and up the back, and you can get some numbness if you're stretching on the nerves.
Yep, thanks, Ken. On that question of office ergonomics, actually, that's very relevant now because a lot of people are working from home and they work long hours. So by office ergonomics, we mean like the way you adjust the height of your chair versus your table, how you position your computer. And we actually see a lot of patients coming in with issues arising from poor ergonomics. And this can be neck problems, back problems, and even shoulder problems. When Dr. Benjamin Ang talked about rotator cuff tendinitis, I see them in my shoulder clinics as well, just from working long hours at a desk, not even doing any overhead activities. Because the way you position your hands on your keyboard or when you use your mouse, if you raise it very high and it's not in a relaxed neutral position where your elbows are close to your body, a lot of times you're straining your rotator cuff muscles over a long period of time, and you can end up with the rotator cuff tendinitis or inflammation that Dr. Ang was alluding to. There's a question for you, Kong Hui, by Irene.
Yeah. Yes.
Can you see it in your chat?
I think I replied her. Basically, I think, Prof, what question is it?
I am having a bit of a problem trying to go through.
Too many questions.
It's jumping a lot. I think the question...
yes, Irene, she is. So
you got
basically,
it?
patella maltracking, yeah.
That's the one, yes. You want to answer that question?
Yeah, I've replied her. So basically, when you have isolated patellofemoral arthritis, which I assume just based on the information given, yes, definitely. Other than replacement, we can do surgical options for it, like lateral release or lengthening. So I mean, it'd be good if she can make an appointment to come down and see us, and then through some physical examination and X-rays, then we can properly ascertain her condition and give the appropriate treatment modality. I think that'll be safer. Yeah. But offhand, general guide, yes, there is non-replacement options for you, Irene, definitely. Yeah.
Thanks, Kong Hui. There's a question on, is it possible to grow new cartilage? So that really is like the holy grail in orthopedics. Unlike skin cells and your hair cells, cartilage cells don't regenerate. Very much like your heart cells, if you like. But this is something where a lot of research is still going on. But at our department, there are procedures that we do to try to stimulate cartilage regrowth. We are talking about procedures short of actually doing a joint replacement. So even for keyhole surgery, we can make holes into the worn out part of the cartilage where you see bare bone. We call it a microfracture procedure, whereby you then hopefully allow the stem cells to grow to the surface and grow new cartilage. But it's a procedure that does not come with 100% certainty that it works. But there are other procedures whereby we get cartilage from non-weight bearing parts of your knee, for example, and then we take it out and plug it into the areas where the cartilage is deficient. So the preservation surgery that Dr. Lee talks about, when we do realignment surgery, the osteotomy that he has shown you, a scope can also be put in, because now when the stress is no longer going through that part of the knee, procedures that I've just talked about may have a better chance of working in terms of growing new cartilage. But this is always something that is not easy to be able to do. Is it okay for old folks to do squats, Sunny? The question.
I was looking at that question as well. So it depends. So there might be a lot of factors that is required for a squat. So it can be range of motion for your hip, for your knee. Strength is also required for a squat. So is it okay for old folks? So yes, it is, provided that you are able to do that comfortably. So must the knee and toes be aligned? If you are doing squats as an exercise, then yes, you want to load it appropriately. But every day, if you are doing squats to pick up something from the floor, then and you are able to do that comfortably, then that's really no need to watch your technique each time that you are going to the floor as well. So again, so the answer to that is yes, you can, provided that you are able to do that comfortably already.
So again, it follows the same theme, right, Sunny? Listen to your body. If
Yes,
you squat with no problems, it means you can squat. If you squat with pain, your body is telling you not to squat. It's the same with the one or two questions asked earlier. Can I climb stairs? So if you climb stairs and you get pain, that means you probably have wear and tear in the kneecap cartilage, not the main joint, but the kneecap. So your body is telling you not to climb. So we advise our patients to take the elevator, to take the escalator, minimize climbing and squatting, so as to prevent further wear. Of course, if it involves your main joint, then you have problems with walking, and that itself is going to be difficult to treat, because not walking will not make anybody happy, right? But if you don't climb, it's not such a big deal. And the question was asked also, why do I go downstairs with more pain than going upstairs? Because that's when you put more pressure on your worn-out kneecap, going downstairs more than upstairs. There was a question asked, I think, earlier to Ben regarding rotator cuff inflammation or tendinitis versus tears. When would you need to consider surgery? You want to answer that, Ben?
Sure, Prof. So for rotator cuff tendinitis, if the tendon is not torn, usually we will not recommend surgery for the cuff to repair, because if the tendon is torn, then surgery can be performed a repair can be performed for a torn tendon. But if the tendon is just degenerate, just tendinopathic or just having tendinosis, I believe physiotherapy is still the mainstay of treatment. And unless, of course, we are going into the shoulder for a separate reason, such as if there is also an element of a frozen shoulder and a capsular release is being performed, then we can, if there is impingement and subacromial decompression is being performed, and acromioplasty. So surgery can be for these other pathologies, but for just for degenerate tendon, we will not need to perform surgery for them.
Yes. Thanks, Ben. There were also a few questions regarding cervical spondylosis. Actually, this is in a way outside the scope of what we have talked about today, but of course it falls under orthopedics, so I think we should address those questions. Neck pain arising from degeneration of the neck spine, cervical spondylosis. It's a very common problem. And often, of course, these patients are seen by our spine team. We also have a very strong spine team of 9 spine surgeons, and they look after conditions about the spine, whether it's in the neck or in the back. But generally, the treatment for cervical spondylosis, again, always starts with non-surgical. So we teach patients to do good physio exercises, adopt good ergonomics like we talked about. They go see our physiotherapists to undergo targeted physiotherapy sessions. and only if the pain gets very bad or if it impinges on nerves and patients feel pain shooting down their upper limbs associated with numbness, perhaps, that's when you may have to do an MRI to determine the severity of the impingement or the degeneration. Only then would you consider surgery. I hope that answers those questions on cervical spondylosis. Any other questions you'd like to take up, panelists? We have not touched on ankle pain, Vincent. Yes, we will be discussing ankle injuries at the next session. Sorry, Prof, somebody wanted to say something.
Yeah, Prof. I saw quite a few questions from the panelists is that they are quite keen to visit us, to make appointment with us. So, yes. Sam, can you kindly update the audience? How do they go about making an appointment to see us?
Yeah. Of course. So PRS, our patient liaison service, Samuel is with us, Mohaimin is with us. They would have the contact number, the email for which you can address your questions to, or if you want to make an appointment with any of us. So again, at our department, we really believe in making our expertise accessible to as many patients as possible. Whether you come in as a private patient or a subsidized patient is secondary, but we are proud of the expertise we have. And we certainly would want ourselves to be accessible to any patients who will need good orthopedic care. Now, there was a question on stem cells, whether it helps to regenerate muscles. Anybody want to take that?
Yeah, I can take that.
Yeah, Ken.
So in Singapore, stem cell treatment is not currently offered. You may for the folks who are tuning in, you may have seen advertisements or may have heard of doctors who may or may not be specialists offering stem cell treatment. Most likely, they are offering platelet-rich plasma or PRP treatment, if not PRF, which is platelet-rich fibrin, which essentially is as what I've described from your blood. Stem cells per se is not mainstream treatment yet, and it is something that has been talked about for the past couple of years, and as what Prof. Andrew Tan has mentioned about new treatments, especially within the realm of biologics. A lot of these are best done in the context of a research study, and it is still work in progress. The stem cells that most scientists are referring to are what we call embryonic stem cells, which is taken from the umbilical cord or the placenta after delivery. So it's taken from a donor, and then it is extracted. It's not something that is done very easily. There are similar things to stem cells. These are amniotic membrane extracts, which you may have read about overseas, where we can inject amniotic membrane extract to try and improve healing of wounds for tendon and joint conditions. But once again, the evidence is still work in progress. And until we can really say it is safe and efficacious, we won't offer these treatments routinely unless it's in the context of an experiment or research. Back to you, Prof.
Yep, thanks, Ken. There's a question on who is the specialist on neck pain. Like I said, we have a strong spine team. And actually, if you want to look at the various profiles of our surgeons, you can visit our SGH website. It is www.sgh.com.sg. And from there, the buttons will lead you to the orthopedic surgery department. Or, of course, you can go through our patient liaison service. The question on what is the optimal table height, chair height, and how many physio sessions to go for. Would you want to take that, Sunny?
Hi, Hi. The question is about okay, I see it now. So the height of the table and chair for good posture when working with the computer. So typically we would want to set the height of the screen or the table first at high level, and then everything else can be adjusted according to that height. So of course you want to, if you are planning to stay in that position for a period of time, then you might want to sit all the way back to the end of the chair, or to the back of the chair, and with your legs supported as well. So my suggestion is start with the height of the screen so that you are at eye level, and then adjust everything from then on. How about the height of the person taking into consideration? So yes, so start with the screen and the level of the screen to begin with, and then adjust the height of the chair from then on. Does that answer the question?
Yes.
Okay.
And the number of sessions of physio, did you answer that already?
No. So again, the number of session of physio will depend. So initial session when the patient first come in, we'll do assessments as well to find out exactly what the impairments are, what the functional issues are, and to target that with exercises and with therapy. So if it's for strengthening, of course, we are foreseeing changes in about somewhere down, say, 4 to 6 weeks. So you, in that sense, will arrange for a follow-up appointment at that point, and then work at that stage and then subsequently also depends on what the end goal is. Is it to return to higher level sports, or is it return to whatever functional activity you are looking at? So it really depends on how you progress and what kind of issues you come in with to begin with.
Yep. Good. Thanks, Sunny. Okay, I think it's 11:50. We will probably have to close the session soon. There are still questions coming in, but I would suggest we will see if Sam can collate them and if we can answer them and then have them posted at the next session. Or some of these very interesting questions, we can also discuss them as part of the Q&A session at the next session. Or through our PLS, the questions can be addressed to our various specialists here today, and then they can reply you via email. That would be another way of doing it. Any last words from anyone, panelists? No? Okay, if not, I want to, on behalf of my team, thank everyone for spending your precious Saturday morning with us. Please keep safe, stay healthy, and we wish you a great weekend, and we hope to see you again next week. Bye-bye.
Thank you, Prof. Thank you, everyone.
Thank you, everyone.
Thank you, everyone.
Thank you.
Enjoy your weekend.
Thanks.